Let's just dive right in. Today, in this explainer, we're going on a fascinating journey into the high-stakes world of the human airway. We're going to explore the delicate, incredibly intricate mechanics of breathing and exactly what happens when that system comes under attack from microscopic invaders. We're talking about laryngeal infections. It's an anatomical battlefield where millimeters literally matter, and understanding the terrain can mean the difference between a minor nuisance and a total critical emergency. Think about this for a sec. What actually happens when a mere 1 millimeter of swelling cuts off your air? We totally take breathing for granted, right? It's just automatic. But the airway is a remarkably narrow passage. When inflammation strikes, that tiny reduction in space dramatically amplifies the effort required to pull oxygen into your lungs. As you'll see, we're going to break down how these infections hijack our anatomy to create these crazy life-or-death physical stakes, and how medical detectives use very specific clues to figure out exactly where the danger lies. Section 1. Anatomy of the airway. Mapping the danger zones. Okay, let's dive into this. So before we can really understand the infections themselves, we have to map out the anatomical battlefield we're dealing with. The larynx isn't just one simple hollow tube. It's this complex structure made of cartilage, muscle, and mucosa. To decode the threats, medical professionals divide this area into 3 distinct zones. And our primary geographical anchor for this map? That's the glottis. It's defined simply as the space between your true vocal cords. I want you to think of the glottis as the airway's equator. It's our central dividing line. Literally everything we talk about today, every infection, every symptom, every level of severity, is measured relative to this specific space. Let's quickly break down these zones. First up, we have this supraglottic zone. That's above the glottis, where the epiglottis lives. Then we have the glottic zone itself, home to those true vocal cords. And finally, the subglottic zone, which sits just below the glottis and leads right down into the tracheal cavity. Identifying the precise location of the swelling is absolutely crucial because it instantly explains a patient's symptoms. An infection at the top zone behaves radically differently than one at the bottom. So let's look at exactly what happens when each of these zones comes under attack, starting right in the middle. Section 2. Laryngitis, the vocal threat. Out of all the conditions on our severity scale today, laryngitis is definitely the mildest. You've probably had it, or at least known someone who has. It targets that middle zone we just mapped out. It's usually triggered by a viral infection like a standard rhinovirus, or chemical irritation from acid reflux, or, let's be honest, just screaming way too loud at a Taylor Swift concert. It directly targets the glottic level. The mucosa of your true vocal cords gets inflamed and just completely bogged down with heavy fluid. Now remember, your vocal cords have to vibrate rapidly to produce clear sound. When they're thick and swollen with fluid, that vibration frequency drops, which completely wrecks your voice. That's why you get that signature hoarseness, or in severe cases, aphonia, which is a complete loss of voice. Is it annoying? For sure. Life-threatening? Rarely. Section 3. Croup, the barking cough. Let's move down and see how this builds. We're escalating the stakes now and moving our focus down into the subglottic area. This brings us to laryngotracheobronchitis, which is quite a mouthful, so it's much more commonly known as croup. Croup is famously caused by the parainfluenza virus, and it aggressively attacks the mucosa of the subglottic cavity. Now, here is exactly where our own anatomy turns against us. The outer rings of the trachea in this zone are made of rigid cartilage. They're fixed in place, so when the tissue inside gets inflamed, it literally can't expand outward. The swelling has absolutely nowhere to go but inward, which severely narrows the airway. When a patient forces air through this tight, inflamed tunnel, it creates massive turbulence. A cough blasting through this space produces a really harsh, barking, seal-like sound, and when they try to breathe in, you hear stridor, a scary, high-pitched whistling noise. To really wrap our heads around why this is so exhausting and dangerous, we have to look at the physics of airflow, specifically Poiseuille's law. Because of the math involved here, if that subglottic swelling reduces the radius of the airway by just 1 measly millimeter, the resistance to airflow doesn't just go up a little bit, it spikes a massive 50 times. 50 times more resistance. Imagine trying to breathe through a wide pipe and suddenly someone swaps it for a tiny coffee stirrer. The sheer work of breathing skyrockets, and the patient, who is very often a young child, can quickly become exhausted. Croup narrows the hallway, and honestly, that's scary enough. But what happens when the swelling doesn't just narrow the passage, but blocks the door entirely? We have to pivot dramatically right now, from the manageable, the frightening symptoms of croup, to a truly terrifying, life-threatening reality. Section 4. Epiglottitis, a medical emergency.
Enter the absolute most terrifying supraglottic villain in this explainer. This is an acute bacterial infection that targets the very top of our anatomical map, and it is a true drop-everything medical emergency. Your epiglottis is a flap of elastic cartilage perfectly designed to cover your airway when you swallow food. But when bacteria infect it, it becomes massively swollen, incredibly heavy, and floppy. When you try to take a breath in, you naturally create negative pressure in your chest. And this brilliantly illustrates the danger. That negative pressure acts like a vacuum, literally sucking this giant, heavy, swollen epiglottis downward, slamming it shut over the laryngeal inlet like a deadly ball valve. The harder you try to breathe in, the tighter the door seals shut. Because it's so critical to catch this before the airway fully closes, clinicians are trained to look for a specific set of sensory clues known as the 4Ds. First step is drooling. The epiglottis is packed with sensory nerves, so when it's swollen, swallowing is just agonizing. The patient simply stops swallowing their own saliva, which leads to drooling. Second is dysphagia, which is the medical term for that extreme pain upon swallowing. Third is distress. You will see them physically struggling and fighting for air. And fourth is dysphonia. That giant mass in their throat totally ruins vocal resonance, making them sound muffled, almost like they have a hot potato stuck in their mouth. You might also spot a visual clue of absolute dread, the tripod position. This is pure primal survival instinct. The patient will sit right up, lean forward, support themselves on their arms, and jut their neck out. This precise posture manually pulls that swollen epiglottis forward just a tiny fraction of a millimeter, just to allow a trickle of air to pass. If you ever see a patient in this position with the 4Ds, you must never agitate them. Do not force them to lay flat, and whatever you do, do not poke around in their mouth. Doing so could trigger that swollen flap to slam shut completely, causing total asphyxiation right then and there on the spot.
Section 5. The bacterial superinfection, when croup turns deadly. We're escalating the stakes one last time to reveal what happens when a viral infection gets fully hijacked. Bacterial tracheitis almost always starts out as just regular viral croup. But the croup virus doesn't just cause swelling. It actively damages the cells lining the airway and paralyzes the cilia. Those tiny hair-like sweepers that constantly clear mucus out of your throat. With the sweepers completely paralyzed, mucus and dead cells just pull up. This creates the absolute perfect, nutrient-rich storm for a secondary bacterial invasion, very often by dangerous bugs like Staphylococcus aureus or MRSA. Spotting this deadly escalation really requires some clinical detective work. See, viral croup gives you a dry, barking cough, a low-grade fever, and the patient usually improves if you give them steroids to bring the swelling down. But if that patient suddenly takes a major turn for the worse, if that dry cough suddenly becomes a wet, purulent, productive cough, their fever spikes dangerously high, they look highly toxic, and those steroids suddenly just stop working, well, you are no longer dealing with a virus. The bacteria have completely taken over. And here is exactly why those steroids stop working. The bacteria aren't just causing tissue swelling, they are actively destroying tissue and triggering a massive immune response. The combination of dead cells, bacteria, white blood cells, and mucus congeals into this thick, physical mass called a pseudomembrane. This is an actual physical plug of pus and debris sitting right there in the trachea. You simply can't shrink this with steroids. It blocks the air completely, which is exactly why these patients are coughing up such thick, purulent material. Section 6. Securing the airway, the ultimate lifeline. So, we've mapped the threats. We've seen the swelling, the ball valves, and the purulent plugs. How do medical professionals actually step in to save the day when the airway is closing? So the crucial point is this: stabilize the airway first. In severe airway obstructions, time is a luxury you literally do not have. You do not send a gasping patient down the hall for an X-ray. You do not wait around on blood labs. You secure their ability to breathe immediately. The diagnosis can very often be visually confirmed while you are in the middle of saving their life. The physical interventions escalate based on the severity of the obstruction. Step 1 is all about buying time. Providing high-flow humidified oxygen can calm the patient, reduce that extreme work of breathing, and improve oxygenation. But if the airway is actively failing, we move fast to step 2, endotracheal intubation. A doctor uses a laryngoscope to physically lift those swollen tissues out of the way and slides a breathing tube directly past the obstruction and right into the lungs. If the swelling is so massive that a tube cannot be passed from above, we hit the absolute emergency rescue scenario. Step 3, a cricothyrotomy. This means surgically cutting directly through the neck to bypass the upper airway obstruction entirely. Once that airway is completely secured with a tube, the medical team can finally deploy their pharmacological tools to actually cure the underlying infection. They'll use dexamethasone, which is a long-lasting steroid, to steadily reduce that subglottic edema over several hours. For a faster response to buy a little time before a tube is needed, they might use racemic epinephrine, an inhaled aerosol that causes rapid constriction of the swollen blood vessels to quickly open the airway up. And of course, if the enemy is bacterial, like in epiglottitis or bacterial tracheitis, heavy-hitting IV antibiotics like ceftriaxone are pumped right into the bloodstream to neutralize the threat.
The anatomy of the human airway is a true marvel of engineering, but as we've seen, it's incredibly vulnerable to just a few millimeters of inflammation. We've gone from the mild hoarseness of laryngitis all the way to the barking alarm of croup, and finally to the silent, deadly trap of epiglottitis. So I'll leave you with this final thought to ponder. Next time you hear a cough or a high-pitched whistling breath, will you know if it's just a minor nuisance or a countdown to a crisis? Keep learning, stay curious, and thank you for joining me on this explainer.